All right, welcome everybody. Thank you for joining us today. We're excited to present a Neurosom webinar. Today's title is The Truth About Getting Good Sleep and Healthy Aging. We're very excited to feature Dr. Ruth Benca, psychiatrist and leading researcher in the fields of insomnia, sleep disorders, and aging. I'd like to hand off today's presentation to Viral Sheth, who is Neurosom's Chief Strategy and Operations Officer, who's going to give a high-level overview today.
Okay, thanks, Marshall. I want to take about 5 minutes to share a little bit of an overview of Neurosom, the problems we're addressing through our innovative solutions and ecosystem, as well as the market opportunity before I pass it on to Dawn and Dr. Ruth Benca to share their insights. It's well recognized that sleep or lack of sleep is an epidemic that's linked to chronic health issues such as anxiety, depression, obesity, and even cancer. In US alone, there are over 70 million people that suffer from insomnia, and globally that number is staggering. Insufficient sleep is also linked with one of the leading causes of death. In fact, the US Department of Transportation estimates that drowsy driving alone causes over 1,500 deaths and over 40,000 injuries on the US roads every year. Now, let's look at the current treatment landscape. Pharmacotherapy and cognitive behavior therapy for insomnia are the standard therapies, but they often produce poor outcomes. For example, pharmacotherapy, the current medications are often minimally effective, they're habit forming, and come with undesirable side effects. On the other hand, and so much so that American Academy of Physicians recommend cognitive behavior therapy for insomnia as the frontline therapy. However, CBTI suffers from shortage of specialists, particularly outside the urban areas, with delayed improvements and poor patient compliance as a result. At Neurosom, we are trying to address this gap through revolutionizing sleep medicine through our HD-EEG ecosystem for sleep assessment at home to transformative sleep therapy using a simple wearable headband device that users can use in the comfort of their own home. This wearable headband system, which we call Sleep Wisp, is basically uses EEG and machine learning to accurately track users' sleep cycle, and it applies gentle electrical stimulation at the right time and the right location to facilitate sleep onset, as well as extend and enhance deep sleep. And this is, by the way, personalized to every individual based on their EEG sleep patterns. This is a quick video demonstrating how easy it is to self-apply this Wisp headband at home. Our technology is backed by peer-reviewed publications, scientific data, and is protected by several patents. A successful sleep study was published in Sleep Medicine Journal that demonstrated that participants lengthened the amount of time that they spent in deep sleep. And this study by Hathaway et al. In 2021 was recently replicated in May 2023, further confirming our results. We've also been fortunate to be featured in national press and Washington Post, as well as Oregon Public Broadcasting. And importantly, our technology is funded by Department of Defense, the MTech project, where we're looking at improving sleep to enhance cognitive performance and performance readiness and active duty military service members that are sleep deprived. We're also funded by National Institutes of Aging to run a clinical trial to improve mild cognitive impairment in seniors at home. Overall, we're hoping that these two projects give us the data that we need to be able to go to FDA to get our deep sleep therapy approved, starting with healthy volunteers, moving on to mild cognitive impairment, and funding permitting, launching a large insomnia trial as well. Now let's look at what are some of the unique value propositions. While a number of companies have introduced technologies and devices to improve sleep using both auditory as well as electrical stimulation, they've largely followed the trend of introducing these products that cater to consumer segment rather than focusing on stringent medical quality management system and running a full-fledged FDA trial to get these devices approved as a medical device. On the other hand, Neurosom already have a stringent medical management, quality management system in place, and our upcoming FDA trials emphasize our commitment to the regulatory compliance, safety, and scientific validation. We also stand alone in the fact that the unique combination of HD-EEG and targeted stimulation are both personalized and effective for both in clinic assessment as well as at-home therapy. And all of these approaches are personalized. Our sleep therapy, we see that as a broad platform therapy that could potentially improve quality of life across many health conditions. But we've strategically identified two major areas of focus based on the market segments that are fairly large unmet need, and the growing scientific evidence. For example, insomnia, there are over 10% of the world's population that suffer from insomnia. And 50 million people suffer from cognitive decline every single day. The sleep health tech market is a massive opportunity. It was estimated at over 14 billion in 2022, and it's expected to grow well in excess of over 20 billion in 2030. Now, Neurosom stands to take advantage and could potentially touch revenue well in excess of 275 million combined across both of these market segments by 2030. Now, to help us achieve these goals, Neurosom has a team of experts that have extensive experience in neuroscience, in technology development, and commercial management. Don Tucker, our CEO, has successfully led a previous EEG company for many years, which was eventually bought by Philips in 2017. In fact, the bulk of our executive team have been working together for well over a decade back from those days and now at Neurosom. We also partner with leading sleep experts across the domain. We have Dr. Ruth Benca today with us, who ensures that our products are scientifically robust and clinically effective. If any of you tuning in today would like to support us on this mission of better sleep, better mind, better you, feel free to contact us. We also have an ongoing crowdfunding campaign that's launched on Red Crow platform that's exclusively focused on select few healthcare companies like us. While this campaign will be ongoing for a couple more months, we have a limited time special promotion that ends end of this month. So feel free to check them out. And with that, I'll pass it over to Don.
Today, we're asking our medical advisor, Dr. Ruth Benca, to help us understand sleep and aging. Dr. Benca is the chair of the Department of Psychiatry and Behavioral Sciences at Wake Forest University and a past president of the American Association for Sleep Medicine.
No, the
And
SRS, the Sleep Research Society. I was on the board of the AASM. I was on the board.
Thank you. Thank you.
That's okay.
And a leading researcher in understanding sleep and a variety of disorders, including psychiatric disorders over the years. But Dr. Benca, today's topic is healthy aging. So why are we concerned about sleep and aging?
Well, I'm going to start out by just adding one thing to Viral's presentation, which was that one of that early slides that showed how sleep increases risk or is associated with many medical disorders. One of the things that you neglected to have on there is the fact that disturbed sleep and sleep disorders probably are thought to account for about 15% of cases of dementia. So sleep is really important, pretty much for all medical disorders and neuropsychiatric disorders, and, just for us to be able to maintain a healthy brain. As we're learning more and more about the function of sleep, we know sleep is critically important for things like learning and memory and just the plasticity of our brain. Maintaining good quality sleep across the lifespan is important. Now, unfortunately, even in normal, healthy people, there are changes in sleep and that we notice. So, for example, when we're younger, we tend to sleep more deeply, more soundly. We have a harder time getting up in the morning. We tend to like to sleep late. And as we age, we find our sleep is lighter, kind of more fragmented. We tend to become more morning types rather than evening types. All of that changes. But the other thing we're starting to learn is that this is based on also changes in sleep oscillations on the brain waves that we generate during sleep. And I've worked with Don now for many years myself. And one of the things we've explored using the technology that he developed, high density EEG during sleep, is that sleep patterns change and sleep oscillations change with aging, and they also change with a variety of sleep disorders. Do you want to pop up one of those slides? We can
I could
take a peek of what happens. Oops, we got there we go.
Okay.
So
here's the first.
Yeah, this is the first slide. This is sort of just the kind of big picture, the important picture. So these were data from almost 100 people, ages 18 to 65, and they were all healthy, normal people. They didn't have any sleep disorders. They didn't particularly have a lot of sleep complaints, and they didn't have any major medical or psychiatric illnesses. And what we did here is we mapped out over the surface of the scalp at each electrode location how sleep oscillations in these particular power bands changed across aging. And slow waves and spindles are two of the most important sleep oscillations during the majority of our sleep, or non-REM or non-rapid eye movement sleep. These are oscillations that only occur during sleep, and they have been tied to some of the important functions of sleep, including learning and memory. And what we see on the left, which is our sort of what happens to slow waves across the surface of the scalp overnight, is that as we get older, we generate less and less slow waves. We also, on the right, generate less and less spindles as we age. And we are now starting to understand that some of these changes are tied to changes in cognitive function as we're aging. And this just shows in more frequency bands across sleep that we see similar patterns. Again, across the top is the absolute power of how all that decreases. And on the bottom is relative power, meaning of the power you do have, where is it changing the most? And I think if you just sort of eyeball these pictures, what we see is in frontal regions, because the top of each circle is the where the face is and the nose is sort of sticking out on top, is that there is particularly loss of activity in frontal regions, and the frontal brain regions are the ones that are most important for cognitive function. They're the most important in terms of brain plasticity. So we're seeing how even in normal healthy people, we're starting to lose really important sleep oscillations for our brain function.
Very helpful, Dr. Benca. Let me ask the obvious question, though.
Mm-hmm.
Are we necessarily, because we lose this kind of healthy young feature of sleep, are we doomed to cognitive impairment with aging? And what causes some people to hold up more or less and other people to progress to dementia?
Well, in the case of Alzheimer's disease, we know that there is abnormal deposition of toxic substances, amyloid beta, amyloid plaques, and tau protein fibrillary tangles in the neurons, and that these accumulate with aging. Interestingly, we now know from work that has been done over recent years, both in animals and humans, that these substances tend to be cleared during sleep, and they're particularly cleared during slow wave sleep. And so this deep slow wave sleep causes the cerebrospinal fluid basically to sort of pulse through the brain tissue and clear out toxins. And so, you know, one of the issues is if we start losing a lot of slow wave sleep, are we less able to clear toxins, which are going to impact our functioning? The other issue we know is that as some of these toxic substances accumulate, the brain is less able to generate healthy sleep brainwave activity. And we've shown, for example, recently that even in people who are not overall cognitively impaired, but just older adults, and particularly those at risk for Alzheimer's disease, for example, that those who tend to lose sleep spindles have greater accumulation of tau proteins, which are associated with various forms of dementia. So we know that there's a relationship between loss of sleep oscillations and cognitive dysfunction, and in some individuals who are prone, for example, to Alzheimer's disease for various reasons, genetic, and also because we know there are many other risk factors like diabetes and other overweight or lack of exercise, et cetera, that sleep disturbances may be very impactful in terms of accelerating course of illness in those individuals.
So you're familiar with Neurosom's preliminary work showing that we can enhance the slow oscillations of deep sleep, basically by putting electricity into the head, synchronizing the slow oscillations and enhancing them. So what is your sense of how we can find out if we could reverse this cognitive decline? For some people, if we can make their sleep deeper, is this going to be therapeutic? I think this is kind of the core question.
That's really I would say $65 billion question. We're past $65 million questions at this point in time. Let me just backtrack a little bit because I wanted to also relate back to something Viral presented about, the way we treat sleep problems. We give medication or we give cognitive behavioral therapy. There are no medications that we currently have that we use for sleep disturbances or insomnia that improve slow waves. And so the abnormalities we see just with normal aging, and of course with things like Alzheimer's disease, which is loss of slow waves and loss of spindles, we don't have any evidence that medications are going to really help that. Certainly not medications that we have now in terms of actually changing the oscillations. We do know in studies in humans that if we disrupt sleep or we disrupt slow wave activity, that there's more accumulation of toxins. So it kind of makes sense that if we could enhance slow wave activity, that we could hopefully not only help the brain clear toxic substances and clean itself better, brainwashing, but perhaps improve cognitive function if slow waves and spindles, and they're working together properly is critical for memory and cognition. So that's what we're trying to do. So, and this has been an approach, I think, that some of the other devices have attempted. So there are various different ways that people try to stimulate slow waves. One is with auditory stimulation. Unfortunately, that doesn't work as well in older adults because of the fact that our auditory systems don't work as well. And so that something like direct stimulation, sort of more top down than bottom up, may work better, which is why the transcranial electrical stimulation approach is more probably appropriate for things like aging disorders. The other thing I just want to mention, because I'm a psychiatrist, people always worried about, oh, if we're doing electricity, are we doing electroshock therapy? This is nothing, and we still do a lot of ECT in psychiatry, and it is a life-saving treatment, but this is not like electroshock therapy. This is a very mild stimulation that is just enough to sort of enhance the brain to naturally produce these slow waves. So that is one of the things we're working on testing right now. And I am working with Dr. Tucker on an NIH funded study where we're going to be testing this device in adults with mild cognitive impairment to see not only does it help improve their slow wave activity, but what effect might it have on their cognitive function? Since there have been studies suggesting in younger people and healthier people that stimulating slow waves may help cognition.
Yeah, no, we're very excited about that trial and really trying to get definitive evidence. Can we really improve sleep where other techniques have not been so successful? So this is going to be an exciting trial to see underway. We're getting started with this, as you know. But I think the encouraging part of the phase 1 has been that we've shown the ability to do home sleep therapy with seniors with mild cognitive impairment. Thanks to your team, as well as our team here at Bell, we've shown NIH that we can do this at home, that we can train people to use the headgear. We can train them to follow the procedure. So now I think we're in the stage of finding out, is this really going to be effective?
I just want to add too that, you know, as we use the technology of high density EEG to study sleep in a broad range of neuropsychiatric disorders, what we've found over the years is that both sleep disorders as well as various psychiatric disorders each have kind of a unique pattern of abnormal sleep oscillations, basically that there's deficits and it's sometimes in different regions and in different frequency bands. But we are now learning how the sleeping brain is really teaching us a lot about neuropsychiatric abnormalities. And then the other thing, you know, I want to add is that in the whole field, I think, of clinical neuroscience, and in particularly for neuropsychiatric disorders, you know, we're really kind of on the verge of moving towards more neuromodulatory approaches rather than neuropharmacologic approaches. Because of course, when we use a drug, we're sort of bathing the whole brain, you know, in a drug, whereas a neuromodulatory approach can target more a particular you know, brain system or brain circuit. And we know that it's specific circuits that are involved in different types of behavioral issues. And that's kind of what we see with our sleep data, is that different areas or circuits in the brain seem to be involved in different disorders. You know, certainly other approaches are including, you know, genetic therapy or, you know, transplantation, et cetera. But we think, you know, that the neuromodulatory approach is going to be something that it can be more widely applicable at more of a population level, particularly when it can be done at home safely, as opposed to, you know, sort of the older standards of like you have to come into the hospital to have electroconvulsive therapy, which of course has a lot of side effects. So these newer treatments are much safer. They can be done at home, large scale, and more cheaply.
That's really encouraging, I think. But it raises for me the next question. Let's say we are successful, that all the early work we've done pans out. We're able to really extend what we've done with younger people, younger adults, into seniors, and we can help improve their deep sleep. How does this work in medicine? So I'm thinking practically. That we have a science advance. How are we going to bring this to the healthcare systems that are dealing with a lot of aging people? I mean, that many societies like the US are facing an increasing proportion of healthy old people. The old people aren't dying off like they used to a few decades ago. They're lasting, but now they may be challenged with mild cognitive impairment or other issues. I guess I'm thinking about the strategy that Neurosom is going to have to develop to bring this to clinical practice. So how do you see the challenges there? Because as you know, sleep doctors have a certain way of doing business, and it doesn't include these new techniques of neuromodulation. What would you recommend as we have successful results and now want to bring it to medical practice?
Well, I think, the first issue is in medicine, we have to sort of move away from treating diseases to trying to prevent diseases. And I think, in the case of neurodegenerative disorders, and many of them are tied to sleep, not just Alzheimer's, but Parkinson's and, basically all causes of dementia, is that once, people start becoming particularly symptomatic, we're not at a state where we can reverse things and, we're just trying to sort of slow things down. But more importantly, what we're trying to do is intervene earlier, particularly in at-risk people, to try to prevent the onset and progression of things like Alzheimer's disease. And I think in terms of sleep, we know that sleep disturbance is probably one of the earliest signs and symptoms for eventual cognitive decline. We published papers, just for example, showing that older adults who simply report, poor sleep have more evidence of Alzheimer's biomarkers than people who report good sleep, and yet they're cognitively not impaired at all. And so one of the questions is, should we be figuring out ways to improve sleep of older adults who are maybe starting to lose their slow wave sleep, kind of as a preventative measure, and seeing if that helps them maintain their cognitive function longer and maybe prevent onset of some of these disorders. And again, sleep is a modifiable risk factor for many illnesses. As we saw earlier, it is a risk factor for many disorders, and it's often a very early one. Depression is another great example. Insomnia, people with chronic insomnia are 2.5 times as likely to develop depression as people without insomnia. And again, one of the reasons that we're frustrated with treatments for insomnia is they don't necessarily correct the underlying abnormality now that we know how to measure it.
Well, as somebody who's not getting any younger, this is very important to me personally. I mean, just looking at how do we maintain our function as long as possible, this preventative approach makes a lot of sense. And I think you're also correct that reversing decline is going to be a big challenge. So it's a matter of preventative treatment. The problem is that the medical establishment, and I'm really thinking of insurance reimbursement, isn't going to pay for this. So are old people going to have to pay out of pocket to get this preventative treatment? Or could Center for Medicaid Services is on the way to going broke? They're not going to try to pay healthy old people to maintain their function. So does Neurosom need to look at our payment model and have a private payment for maintaining your health and aging rather than a medical disease model?
Well, certainly there's a market for that. There are plenty of people who engage in, concierge services, who pay a lot of money for, preventative treatments, buy things over the counter to improve their health. I mean, look at all the people that take that jellyfish stuff, for their cognition that
Right.
does nothing. So there's a lot of money. And then just what people spend on sleep out of pocket, we know is, huge sums of money. So, it really depends on the price point. And I think, people who know they're at risk of cognitive decline are, very motivated to get treatment. And I think, the other issue, as we see in, even in medication pharmacotherapies, is that once something gets into more widespread use and there's increasing data that it is helpful, you're more likely to see insurers, start to pay for it. I think the other thing to keep in mind is when you start thinking about the WISP and even the neuromodulation, also just the recording, is that with older adults who are wanting to stay in their home environments, is that the more monitoring we can do of people in their home setting, monitoring of their behavior and their data that then can be looked at, the safer they feel being at home, and their families feel, knowing that they can be checked. And the more we can bring physiologic testing into the home setting, actually the cheaper it is for the healthcare system.
No, that's very helpful. These are going to be some of the challenges, I think, to be creative in this setting. Well, let me turn to a question and answer session. So, Marshall, should we open this up to questions from participants? And are we able to do that then? Do we have questions in the chat?
For anyone attending today, there is a Q&A chat session. So there should be a Zoom option for you to enter your questions, and then we can go through them one by one. Our first question here is, I've read a study that related slow wave to resetting the hippocampus. Do you also see a correlation here? Secondly, is the stimulation similar to what is currently used for seizure treatment? So first part is a study that related slow wave to, quote, resetting the hippocampus. Do we see a correlation with the stimulation that we do here?
Let me try to start with that. It's a very interesting question. And these are the mechanisms of memory consolidation that we think are engaged by slow oscillations. So there's a literature that does show hippocampal involvement in the synchronization of slow oscillations. And again, we think that's important to particularly the explicit memory that's improved by non-REM sleep. And non-REM sleep is when we have the slow oscillations. Now, in our human studies, we don't see hippocampal activity because we're not recording it. It doesn't come out uniquely. But we do think that could be a mechanism for understanding it. What was the second part?
Is the stimulation similar to what's currently used for seizure treatment?
Interestingly enough, it is, but in a different way, a different mechanism. So we have done a study of long-term depression of activity as opposed to long-term potentiation. And slow stimulation does decrease the excitability of the cortex. But I actually think that's a whole different realm of neurophysiology, because we're not decreasing excitability with synchronizing the slow oscillations. So it's very interesting. I mean, I think the first concern that people have is if you put electricity in the brain with someone who has epilepsy, is that a risk? And we say, yes, we want to be careful with anybody with epilepsy. On the other hand, when we actually treated people with seizures, we could decrease their epileptiform discharges with this stimulation. So from a practical sense, we think that that tells us this is a safe intervention. But mechanistically, it's very interesting that there are parallels between these.
Yeah, I mean, I know Marshall wanted to say something too. I think we just have a paper coming out looking at emotional memory processing in adults and the importance of the so the slow waves interact with the hippocampus to facilitate that. And I think, we're seeing evidence of that being important in older adults. Marshall, did you want to add something?
No, thank you both. I was just going to ask anyone to open up any more questions. It's a great question. So,
yeah.
Stating that this person is excited about the clinical trial, and one concern that is raised is users of the technology such as WISP, and how the privacy of their sleep data is going to be held, and the comfortability of having their sleep data collected and the management of that data from a privacy standpoint for patients.
I could just
Very
say
good
from
point.
my perspective that we've got to be HIPAA compliant with everything. And certainly, in terms of studies, any kind of data that we're collecting when we're doing either a clinical study, a remote study, because we do a number of remote studies for, various types of data, that is protected. It's personal health information that we can, we're not allowed to share. And Don can talk more about it from an industry standpoint.
No, that's exactly right. We're required by law to protect this as personal health information. And the way we have to do it is quite regulated. We have to demonstrate cybersecurity of each of the protocols that we have. So in the Neurosom electric sleep therapy, we do score the sleep online. That's our AI or machine learning that allows us to characterize the sleep quality instantaneously. That's actually how we can do the intervention in a closed loop, is by machine learning scoring the data online. So all of that is then uploaded to the Neurosom cloud so that we can give reports to the physician. And that's part of our model, is being able to do that. That whole process has to meet stringent cybersecurity standards. And that's part of our quality management system and part of our FDA clearance. And FDA is getting very careful and vigilant about cybersecurity. So in fact, now we have an expert cybersecurity firm stress testing our security, actually trying to hack into our system to test if we have vulnerabilities. And it's actually a pretty big expense of developing an entire system. But that's the modern world now, is that we have to maintain cybersecurity, and we have to show a validation of our cybersecurity methods on an ongoing basis. So it's part of the cost of doing business here.
So data will not be sold to Mark Zuckerberg then.
That's correct.
Absolutely not.
Yeah. And a next question is asking about using sodium oxybate to increase slow wave sleep.
Well, there are some drugs that are associated with increases in slow wave sleep, and sodium oxybate is one of them, but it has a lot of other effects as well. And it is a very challenging drug to use and has a lot of side effects. As a psychiatrist, I am concerned about some of the psychiatric side effects I've seen with sodium oxybate, ranging, from psychosis to, agitation. And the other thing, of course, is it can be addictive. It has to be highly regulated. The regular sodium oxybate formulations really have a lot of sodium in them, which isn't particularly healthy. So it's not really fixing sleep per se, and is got a lot of drawbacks to it, I would say. It's not my favorite drug to use.
All right. And then
Prescribe, I'd use it, but yeah.
And a next question is asking if the AI sleep algorithm that we have is scoring all data collected rather than just sleep staging.
Well, we record all the data, so we have all night EEG. But right now, the machine learning technology we have, its main focus is scoring sleep staging. So that's the output. We generate a hypnogram, and part of our FDA validation is that we compare that to human expert sleep scores. We actually have three sleep scores.
And me.
And you as an outside expert, that's right. And we are now submitting the machine learning to FDA and compare it against those human scores. And it's close to as good as the human scores. I wouldn't say it's better at this stage, but it gives us essentially the same results from particularly the sleep stages we're interested in. So that's an integral component. Now, there could be other things that we could do once we have this machine learning technology, and we're very interested in that. For example, could we predict who's going to have memory impairment from the EEG? It may not be in the standard sleep scores, but once we have a massive data set like this, we know that AI is very good at extracting regularities. So this is a future direction of not just looking at the conventional sleep stages, but to look at additional things we might detect with the AI. Now, to be clear and kind of keep continuity here, FDA requires us to do validation on any of the AI techniques and to show that they're not over-specifying the sample data, but they will generalize to people in general. So everything we do has to be validated and tested.
Yeah, and then the other thing I just want to add is that, when AI is scoring sleep as, non-REM or REM, I mean, one of the reasons we have to have something that in real time is evaluating at that moment, is the person asleep or not, and are they in non-REM or REM sleep, because the algorithm then needs to know to do the closed loop stimulation. In the old days, we used to do these types of things by having a technician sitting there with a person in the lab and watching the EEG and then delivering the stims when we saw the slow waves develop. But after the fact, we can apply things like our spectral analysis to look at the spectral part, because again, that's really the more important thing, and we have that data collected, and then we can analyze it separately, and we can also review it ourselves as we do every clinical sleep study to verify that the scoring is accurate. Well, here's some more questions.
Yeah, next question. Asking about a study that indicated that CPAP therapy increases overall sleep duration in patients with obstructive sleep apnea, but that it surprisingly does not enhance deep sleep duration. And asking if we could comment on the potential implications for the WISP that has the ability to target deep sleep directly with the population of patients with obstructive sleep apnea.
So I'm going to say two things. First of all, in terms of what treating sleep apnea does to deep sleep, it kind of depends on how bad the sleep apnea is. Certainly, I've seen plenty of patients who, if you've got an apnea index of, 60, meaning that at least 60 times an hour you're stopping breathing, I can guarantee if that's fixed, you're going to have probably more slow wave activity, because you can't get into slow wave sleep if you keep waking up repeatedly like that. But give that aside, this is what's really, I think, interesting about the WISP. So it could apply to sleep apnea. And we know that people with sleep apnea, sometimes even when their apnea is treated, they're still tired and they may not be generating a lot of slow waves. The other issue is, again, with pharmacotherapy, as I mentioned, some of the newer agents like the orexin receptor antagonists eliminate wakefulness, but they don't increase slow wave activity. So one of the interesting questions is, could you use the WISP on people with sleep apnea who are being treated, or on people taking sleep medications that might help them stay asleep but don't necessarily improve their slow wave activity? And in fact, in the study that we're about to do, that we're in the process of doing actually with the people with mild cognitive impairment, some of those individuals will be on CPAP. So we will see how the stimulations may improve slow wave activity in treated individuals with sleep apnea.
Great. Thank you, Dr. Benca. A next question is asking if there is a possibility for a smaller miniature version of this technology that could be developed for use in experimental animal models, commenting that it could be a great resource for technology in preclinical research.
Yeah, that's a very interesting question. And I think without a doubt, in fact, there's a lot of progress in miniaturization and intracranial recordings in animal work. So I think we would be very interested to parallel with labs doing that. And in fact, we regularly review the research literature looking at animal models and intracranial recording. And a lot of what we know about sleep comes from animal models. So for example, this question about the coordination with the hippocampus that we were talking about earlier is really essential to understand the mechanisms of memory that we cannot see from the head surface EEG. We need those intracranial animal models. So I fully agree that the animal work and bringing the kind of closed loop AI stimulation paradigm to animal work, that's going on right now. And we're trying to follow that and understand the implications from it. Now, will we have more effective non-invasive or more effective invasive intracranial recordings in humans? It's an open question. Right now, we're seeing that when you poke electrodes in the brain doesn't like it. Intracranial electrodes, the neurons, there's not good progress with making those compatible with intracranial recording. So the studies in humans, clearly in epilepsy, we need to do that. There's a good clinical justification, but beyond that, we need some significant advances so that the neurons aren't damaged by the intracranial electrodes. Now, I think there will be developments in this area. I do think there will be future for intracranial devices. There are hydrogel electrodes that don't require the metals that we use for electrodes now. And so I can imagine it won't be long before we see breakthroughs in intracranial recording. But right now, we're impressed with how much we can do with head surface recordings.
And there's also, technology being developed to sort of affect deep brain structures through application of surface, either electromagnetic or other types of energy stimulation, basically.
That's right. That's right. And the acoustic stimulation, ultrasound techniques are a new modality there. That's right. So I think there'll be plenty of technology in giving us some new windows to use.
Good deal. I would just like to open it up to questions again.
I'm going to just add one more thing about the headband. One of the other applications which I think is going to be really important separately from the closed loop stimulation is just the ability to record sleep. And I think there's a growing market for that, in terms of research studies where we're, really trying to do larger scale population-based studies, to look at sleep patterns of people in their home settings, which is where people, tend to sleep, and we want to see how they're sleeping at home. And I think also the development of, the ability to do sleep diagnostics in the home setting, that these types of devices, particularly where we can collect EEG data, and that's been a sort of a drawback of a lot of the other home, for example, sleep apnea testing devices, that we don't see the EEG, and we're starting to become, more aware of the importance of being able to see sleep EEG to make proper diagnoses of various disorders and to determine treatment effects.
Yeah, very good point.
Maybe I'll ask one final question to Dr. Benca if there are no more. Dr. Benca, what do you think about, as Neurosom is thinking about our business model for WISP therapy in particular, considering the private clinic models versus large academic medical centers, then do you see any major differences in terms of the best practices, in terms of maybe how these private clinics approach their business model slightly differently from large academic medical centers? And I say this from sort of some of our early experience with a large private clinic in Bay Area, where they use a completely unique business model to do pay-as-you-go sort of a model for these clients. And we were wondering how that might be unique towards private clinics versus, let's say, large academic medical centers, as we think about sort of return on investment for these devices.
Well, yeah, I think, in medicine in general, we're, sort of at the whole economic system is in a state of transition right now. We're seeing healthcare systems consolidating. We're also seeing kind of private enterprise or private companies developing healthcare approaches. We certainly see that a lot in mental health and behavioral health services. So I think, you kind of have both ends. You're going to have a lot of clinics that are going to basically, be taking cash money instead of insurance, and people who are going to pay for that so they can have access to new treatments. And on the other hand, in the academic medical centers where, we're trying to do cutting edge research and figure out the new therapies, there's going to be a market there. It's the same thing with new, pharmacotherapies too, is that there's always a challenge to get things adopted on a very large scale that aren't covered by insurance. On the other hand, if you have something that's really effective, look at the GLP-1 agonist drugs right now. People are paying a lot of money out of pocket for those drugs, like $1,000 a month. So I think, there is a market for treatments that are going to be effective. And, along those lines, we know that sleep deprivation and inadequate sleep is a risk factor for obesity, and insufficient sleep is a risk factor for obesity. So, there's a lot of, potential ways to, sell things that people may need to pay out of pocket for if they're really effective.
Makes sense. Yeah.
Right. Yes. So Neurosom is currently crowdfunding, and the RegCF raise can be found through Red Crow's platform. Unfortunately, I think I'm unable to drop the link in the wider chat, but maybe
redcrow1word.com.
And
Yeah.
Viral,
And feel
maybe
free to reach out to us if you need help navigating through that. info@neurosom.net. You could reach out to us and could help guide you and put you in contact with the right people at Red Crow.
And again, that's info@neurosom.net. Just send an email and we'll be able to help guide you through that process.
Great. So as we wrap up, I want to thank you, Dr. Benca. This is extremely interesting, and your perspective is going to continue to be important as we kind of navigate the next steps with this clinical trial, but also with bringing the Neurosom products to market. So we are going to continue to be asking you these questions about how do we fit in the medical system? How do we fit within the science?
So much. Looking forward to the results as we keep moving this forward. Yeah.
That's right.
I think that does it. All right. Thank you, everyone, for attending today.